Okay. Well, good evening, everyone. We'll call the meeting to order of the DuPage County Health Department of May 14th, 2020. Do we have any public comment, Penny?
No public comment came through.
Okay, there being no public comment, we'll take a roll call, please.
Ms. Bottoms?
Here.
Ms. Finch?
Here.
Okay.
Dr. Hussein?
Well, good evening, everyone.
Mr. Larson?
Here.
Dr. Munir?
Here.
Dr. Scouten? Mr. Spadoni?
Here.
Mr. Thurston? President Tornatori?
Here.
Dr. Weeks?
Here.
Dr. Wilson?
Here.
Mr. President, you do have a quorum.
Thank you. We will shortly be hearing from Jason Coyle from Baker Tilly. He's going to provide comments on our financial audits. And then, well, I guess we can start with him and then I'll continue on. Karen, is Jason ready for us?
I
am. Can you guys hear me?
Yes, thank you.
Karen, we can't see
well,
you, by the way, just so you know. I can't see you, Karen.
I can't see anybody. Is that correct or?
I'll be right back.
I can see you, so I don't know why you can't see us.
I had everybody and then the whole screen went out, so.
I can see you, Lisa.
I'm just checking. Can you hear me now?
Yes.
Yes, although you're
Okay.
not going through your computer audio, you're going through another way.
Correct, yes.
Okay, Jason, wherever you're at.
All right. I'm just on audio, so I can't see any of you guys, but I'll just give you a brief recap of the audit. I'll keep it very brief because everything was great this year as it usually is. So we provided what we usually provide, which is an unmodified opinion on your financial statements. So that's always great. It's the highest level of assurance we could provide. And in layman's terms, what that means is that people can pick up your financial statements and rely on them in all material respects as they evaluate the financial health of the health department. So congrats on continuing to receive that. I do always like to say when I'm speaking to boards to read the front section of your report called MD&A or Management's Discussion and Analysis. I know not everyone wants to thumb through all these long governmental financial statements, but I always encourage board members to read that just because it summarizes what went on during the year and provides a little bit of narrative. So I won't go into that, but I do encourage you to read that. I know one board member had some questions on your pension liabilities. Your pension is, so let me address that just quickly. Your pension, IMRF, it's a great pension plan to be in here in Illinois because it's typically very well funded, unlike many of the other pension plans, unfortunately, in Illinois. So you're fortunate to be in that. And you're in the plan with the county as a whole, so you're kind of a carve out of that plan. So there's some fluctuations between last year and this year in IMRF. The net pension liability increased quite a bit. And then there's some other components called deferred inflows related to pensions and deferred outflows related to pensions. So if you were to look at each of those components individually, you'd see some big fluctuations between one year and the next. And the big reason for that is because of the stock market. And when the pensions were valued, the stock market had taken a big change from one year to the next. And so that's a big reason for some of those changes. I always recommend looking at those changes collectively and considering it that way. Because what happens is as that net pension liability changes, some of those changes are amortized over 5 years in the deferred inflows and outflows. So if we were to look at the net pension liability with the deferred inflows and outflows from one year to the next, there was actually a relatively small change, only $262,000, even though the individual components changed quite significantly. So I know there's a little bit of detail there, but I wanted to provide some insight into that. Overall, it was a good financial year for the department. Fund balances increased $1.1 million. And the net position, which is a slightly different basis of accounting, increased $2.6 million. The difference between those two largely driven by when revenue is recognized on the fund level compared to the entity-wide level. So, overall, a good year financially. We like to see fund balances and net positions increase. The other thing I always like to mention is when we come in to do the audit, we always kind of kick the tires on the internal controls or your checks and balances. And if there's anything that rises to the level that we need to report it, something that we see needs to be improved, we do that. And thankfully, again, this year, we didn't have anything that needed to be reported. So that's always good news that, nothing came to our attention that requires improvement. So I think the only other thing I'll mention is with the COVID-19 pandemic, GASB, the Governmental Accounting Standards Board, just issued a new statement in the last couple days, really, that extended several GASB pronouncements that need to be implemented by the department. So that gives you another year on several statements that you'll need to implement over the next few years. Gives you a little breathing room. Thankfully, some of them are rather significant, like the new leases GASB that'll change how leases are recorded in your financial statements. But now you get a whole nother year on that. So outside of that, we did perform a single audit where we audit one of your federal grants, and happy to report we didn't have any findings on that program that we tested. So great news there as well. And with that, I guess I'll open up to any questions, or if you want me to go in more detail, I'm happy to do that as well.
If anyone has any questions, just raise your hand and then I'll recognize you and you can ask that of Jason. Anybody? No? Okay. Well, Jason, if you've concluded, then thank you so much for what you've done, and thanks for the great report in more ways than one.
Yeah, thank you. Thanks for letting me be with you this evening. Appreciate it.
Okay, thanks. Enjoy your evening.
Okay. Bye-bye. Thanks. Bye-bye.
Congratulations on a good audit, guys. Great job.
Thanks.
Good job of the team.
Okay, we will move on, and under the balance of my president's remarks, soon we're going to be hearing about our response to COVID-19. But a couple of things. There's going to be an ad campaign that's going to be launched soon to get people to understand to not wait for other important healthcare problems. I think so many people have been focused on COVID that they've put off some of their other health issues, whether it's appointments with doctors or taking care of some chronic illnesses that they have. So we're going to engage that. And to that end, you may or may not have read in the newspaper about our coroner, Dr. Jorgensen, highlighting in the last 3 weeks, we've had 22 overdoses from drugs. And he doesn't think that they're from bad drugs. He thinks that it may be related to domestic issues, marital problems, isolation, any number of other things which have caused people to move into the dark side. So it's going to be important to let people know that they've got to continue to take care of their health in general and not just worry about COVID. Wanted to inform you about our issue with NAMI. NAMI is going to be reducing their footprint by about half, as I understand it, and will be reducing their rent to us by the proportionate amount. And we're going to be moving our substance abuse staff from the courthouse over to the community center effective June 1. So Karen deserves our thanks for negotiating that rather sensitive issue with NAMI, and has done it, I think, to the satisfaction of NAMI as well as us and all the people who have helped Karen as well. Before I turn it over to Karen for our public health update and to Dr. Chu, let me just say that I'm sure I speak for everybody when I say congratulations to Karen, all of the senior staff, all of the staff for the magnificent job that you've done throughout this crisis, not only keeping us informed, but keeping us healthy. You look around and you see question after question that is being posed to us and obviously being posed to all of you at the health department, and you always have an answer. And even if it's not the answer that people are looking for, you have the answer, and it's based on data, and it's based on decisions that are public health related and driven. So to all of you who have been working many long hours, anybody that thinks it's easier to work from home hasn't worked from home. So we all know how difficult that is. And if you've gone to the office, you know what that's like as well. So until we get past this, and at all times, as I've always said, I'm very, very proud to be associated with the DuPage County Health Department, and congratulations to Karen and your entire team, and all of us who've had all of you have had a small part or a large part in it as well. With that, Karen, I will turn it over to you for our public health update.
Thanks so much. And before I launch into the presentation, I have an email, Dennis, that you sent that has an update on our DuPage Health Matters fundraising efforts that I think warrants letting the board know about. So do you want to share where we're at with our fundraising efforts?
Yeah, sure. The we got a match of $5,000 from an organization. I sent an email out on that this morning. If we raise that $5,000 by tonight at midnight, it's matched by another donor. Anything up to that $5,000, they're also matching. Part of that today, really just about a half hour ago, the Page Foundation donated $1,500 in honor of Karen as the leader of the department. That's on there already. It hasn't been matched, but it will be. And we've had several other donations come in yesterday and today. So right now, we're up to $7,650. There's still room there to get up about 10,000 or so. But our goal originally was 7,500, so we've reached the goal at least.
Very exciting, very exciting. And the community has been incredible in supporting us and really providing us with encouragement. So I think we're going to have the PowerPoint now come up, Luke, by the magic of technology. Great. So next slide. Going to be providing my comments pretty much in 6 buckets. And I am going to be doing the presenting this evening, but in no way am I responsible for all of this work. And to Sam's point, this has been an amazing team process. We speak with each other at least 3 times a day. Most of us speak much more frequently, and in between those times of touching base, everybody does a whole lot of work. So what we'll start with is disease monitoring. We'll go into some more detail about public information, health education. We'll talk about the PPE distribution that we've been involved in. We'll talk about the housing support that we've become involved with, how we've been sharing public health guidance with our local partners, and then finally, how we're approaching and dealing with our own operations. So next slide. Just kind of just stage set, today we announced an additional 223 cases that were confirmed in DuPage County. So now we're up to 5,457. The state of Illinois is clearly approaching a new benchmark of 90,000. We have also had, unfortunately and tragically, 278 deaths associated with COVID. Next slide. We have been maintaining this dashboard since March 30th. And like most things, we don't just want to plop up a product and then call it done. We have been consistently improving and adding functionality and data to it going forward. So at this point, I'll ask Chris to pull up the actual site and walk you through some of the elements. While he's doing that, I would like to provide a shout out specifically to Dr. Tube leading her team in CDEPI. They've been setting goals weekly to distribute additional data to better understand the presence of the disease in DuPage County, and have done a phenomenal job in pulling together additional information for our residents to be able to watch and utilize. Chris?
Yeah, can you hear me?
Yeah.
Okay, excellent. Yes, and thank you to Rashmi and her team for providing this data. It's certainly a challenge to do as much investigating of cases as we've done and then turn around and make it publicly available to display all of this. So thank you to her team and to the county GIS staff, Tom Ricker and Kevin Pirano, who've done a remarkable job helping us to get this out. Hopefully you're all familiar with this dashboard. I'm going to highlight a couple of the new things that we've added just in the past week. And this is the internal dashboard that we are using to preview things before they're public. So some of these things you won't see on the public site until tomorrow, but we wanted to give you a preview of some of these new data points. So as Karen said, the number of cases rises every day. We're just over 5,000. You can get a snapshot through the dashboard here every day. Any of these charts here that you see can be expanded. So depending on what device you're on, if you're on a phone, on a laptop, on a tablet, you can blow these up to really be able to analyze the data a little better. So this shows cases by age group and underscores the fact that we're really seeing this across all age groups. Thankfully, not many children at this point. Certainly some new concerning news coming out of New York, but we are seeing cases in all of our age groups so far. The bottom left corner here gets into more of the case data. This is one of the charts that we want to highlight and kind of point people's attention to. Most frequently is the number of cases reported by the date reported. There's two lines on here. I'll draw your attention to the red lines. The red lines are a 7-day rolling average. So it helps us give some perspective on how these numbers are changing over time. And the positivity rate gets a lot of attention in terms of how many people test positive. But as the health department, we think it's also important to draw attention to the sheer number of people that are being affected. And therefore the workload that then translates into contact investigations, contact tracing, making sure these folks know that they need to isolate and how to do that safely. So the sheer volume of cases is clear on this chart. We've added some new data today that'll go live tomorrow on the percent of tests that are positive. So this is a new chart that shows the total number of tests run every day for DuPage County residents, regardless of where they're tested. Blue bars on the bottom show the number that are positive every day, and the gray bars stacked show how many negative. And then you all are probably watching this as close as we are, as well as the media and the public, is the positivity percentage of those tests. So the number of positive tests divided by the total number of tests each day. And so you can kind of watch this fluctuate. The state's target is 20%. They have 14 days below that. So we'll be watching that closely over time, and you can follow along with us here. We've also added data this week to the center panel about municipalities. We've been committed to getting data to municipal leaders and to residents as quickly as possible about their own towns. And in the past week, in addition to these bar charts that have showed the total number of cases and deaths, we've added a breakdown that shows how many of those cases are related to outbreak settings versus those that are what we call community cases, that are just individuals who are identified in the community one by one. In terms of cases, we see that most of the cases are these blue bars, which are community cases, meaning they're not linked to a congregate site like a long-term care facility or a workplace. So the vast majority of cases that we see in every municipality are community cases. In contrast, you'll see that we've provided data on deaths, the same breakdown, deaths that are community, individuals that were living alone in the community or living in a single family residence, versus these outbreak settings that are typically long-term care centers. We see that most deaths are related to a congregate setting or a large gathering. So that's new this week. What I will also, on the right side here, we break down the hospitalizations and deaths. So getting into the more severe cases, you'll see the total death number, and then you'll see a number of charts here in this right pane that you can expand out and select to look at deaths by sex. You can see a pretty even 50-50 split between males and females. Deaths by age group, that underscores the tremendous toll this disease has taken on our elderly residents. Hospitalizations by sex tend to be a little bit more male. And we've also added data to show hospitalizations by age group, really trying again to help people understand that it's not just those 70 or 80 years plus that are having severe health outcomes related to COVID. We are seeing hospitalizations in almost all of our age groups here. And finally, in the bottom right corner, some information about hospitalizations and deaths over time. You'll see cumulative totals for hospitalizations and deaths. Our first case was identified on March 13th. So step back and think that just 60 days ago, we had one case of COVID-19 confirmed in DuPage County. So to come from there to 60 days later to have over 5,000 cases and almost 300 deaths is really remarkable. So you'll see the cumulative totals here, the number of deaths by day. And we were just cautioning on these death and hospitalization charts that the last 7 to 10 days are really not complete because of the lag in reporting. But we want to get it out there in terms of the data that we have now, with a caution that that data will be updated as more information comes in. Cumulative hospitalizations, same concept. We've had over 1,000 DuPage County residents hospitalized as a result of this disease. And then you can see the totals by date. Encouragingly, we have seen a downward trend over the past 2 weeks in hospitalizations, and are watching for that number to continue to come down. And again, those last 7 to 10 days should really be interpreted with a little bit of caution. Finally, on the map, just to highlight one of the other features that we've added at the request of many of the partners that we work with, is up in the map corner here. We've added layers to show the last 14 days for cases, hospitalizations, and deaths. So the map will show all COVID cases over time. You can toggle that off and be able to see just the last 14 days, which gives us a better sense of what's going on today in the community, and not just the total over time. So you've got options to toggle those off, on or off. So that's the map. And the last thing I'll draw your attention to before giving it back to Karen is that on our website, we have added data beyond the interactive dashboard to this dashboard website. So underneath the dashboard, you'll find that there are a number of new data options related to cases of COVID-19 broken down by ethnicity, race, severity, affiliation with long-term care facilities, whether they have underlying medical conditions, and that positivity chart. So if you expand any of these boxes, you can see these disparities that we're seeing in terms of the people that are being diagnosed with COVID-19. So we'll be adding, this information is updated weekly. So if you are interested in a deeper dive into how this disease is affecting our community, we would encourage you to take a look at these. And if you have questions, to let us know. And with that, I'll turn it back to Karen.
Thanks, Chris. This is fantastic data. I look at this every day. Excellent.
Excellent. We're glad it gets to good use. It's important to get it out there and important that people are seeing it. So thanks.
This is Bob. Can I just ask a question? So can you go back to the bottom left graph, the graph on the percentage? So if we're looking at the percentage lines, and you've indicated that in order to move from one phase in the governor's plan to another, one of the things they're looking for is 20 straight days with a positivity rate below 20%, correct?
I think it's 14 days.
Or 14 days, I mean, below 20%.
Yeah.
So we as a county are basically there, right?
Yeah, we're pretty close. And the only thing I would say to that is that we're trying to work with the state to understand if it's 14 consecutive days under 20%, or if it's a 14-day average that's under 20%. And I'll be honest, we haven't gotten clarity on that yet. But your point, yes, we're very close as DuPage County.
Okay, because obviously, we're getting a lot of pushback from residents as to, when we're going to lift some of these restrictions. They're killing businesses, and I want to make sure that our statistics are accurate and they're not being misinterpreted by the state, or one day out of, we all know that numbers spike on Mondays, after weekends they go down. And, to the extent that we're not getting accurate feedback from the state, please let us know. I can speak to Chairman Cronin. We can, he has the governor's ear on some things, and make sure that we understand that DuPage County is given the appropriate flexibility to address the concerns of the residents and keeping them safe, but based upon numbers, not based upon Chicago's numbers.
Mm-hmm. Yeah, it's a good point. I think today in Dennis's communication, he identified that this is the first day that the Northeast region has met that 20%, under 20% threshold. So even with Chicago, we're getting close. But point taken that, yeah, if we need help, we'll let you know, because it has not been easy to get all the data and information that we need to be able to share with our residents.
Thank you.
Seems like an odd parameter because, as you know, a lot of the elective surgeries, the procedures are starting to ramp up. And so this is just a denominator issue, right? There's going to be a lot more testing of people that we know are going to be negative. So I don't really understand the logic behind 14 days and 20%. To me, that's the numbers don't really match the symptomatology.
And
yeah,
and this is a point we may bring up and discuss later. I was going to bring it up on new business, but one of the sore spots for DuPage County, and something I think that Chairman Cronin is going to bring up with the governor, is we don't have a non-sick testing facility in DuPage County. None. A bunch of them across the border in Cook County. We don't have one here. So we have no place for our residents who aren't feeling ill to go to get themselves tested. And again, as Dr. Hussain said, that's going to skew the numbers somewhat for our residents.
yeah,
Absolutely. So we'll continue to work with both testing as well as understanding the spread, because I think it's been alarming in several cases that people came back with a positive test who had absolutely no symptoms. And so just simply to better understand the way the disease is being projected across our community, I think is really very important. And yes, I think the denominator increases will help us, and amen to the fact that DuPage has kind of been overlooked for community-based testing opportunities. So we look forward to that.
Karen, this is Sam, and before we move off the graphs, just wanted to commend Chris and Dennis for the job that they've done too, and keeping us informed. Every Monday morning, we have a meeting with all of the mayors in the county, and Chris leads the mayors with Karen and Chairman Cronin and myself through these statistics. Takes questions from the mayors, and it's seemed to have been very helpful in that. And of course, Dennis daily sends us, not only as board members, but sends to the county board members as well, an update every day of what's going on, which has been very well received by both the county board members and us. I have a question, and it's the same question that I asked on Tuesday, and it's to Karen, it's to Chris, it's to Dr. Chug. I understand the 20% positivity rate, and that 20% and that percentage is derived by taking the number of people who test positive over the number of people who are tested. And that's fine, except I think that the denominator in that fraction could also be changed or amended or added to take a greater number of people to be tested, because it's obvious to me that currently the people who are being tested are people who are sick or who think they're sick. And that would indicate to me a greater percentage of positivity, that if we were to have some community-based testing that would randomly, if you will, select a group of people, just like they would do political polls, if you will, throughout the county based on gender, age, ethnicity, geography, and come up with a percentage of what we believe the virus has affected throughout the entire community. That to me would be not only a better indicator of how the virus has affected us, but also would be able to target, if we did it the right way, hotspots, areas within the county that we may have people who are positive in one area of the county as opposed to others. Right now, we don't even know where the people are being tested, where they're from, because the only testing site is Aurora. So it would seem logical, again, to assume that those people who want to get up at 3 a.m. to wait in line to get tested are more than likely going to either be from that area and from that part of the county, and certainly are going to either be sick, feel sick, or think that they're on the brink of getting COVID, which again would raise that percentage up. I continue to get this question by mayor after mayor and elected official and family and friends saying that the positivity rate is skewed here because we're testing people who are sick or who think they're sick as opposed to the general population. I know that's called community-based testing. I learned that the other day. Why are we not doing it? If not, why not? And I think that, and I've had this conversation with Chairman Cronin, I think we could find the money to do it because I do believe that it would give us a better and make us be able to better quantify how this virus is affecting the entire community. I'll throw it out to any of the experts and tell me whether I'm barking at the moon or whether I have something on here. Nobody wants to take it on. Okay.
No, I can.
You're not
Can you hear me?
Yes.
This is Rashmi.
Okay.
Yeah.
All right, Rashmi, thanks. Go ahead.
Sure, thank you. So I think it's an excellent question, and I just wanted to clarify the graph that we're looking at is a reflection of total positive tests over total tests performed. So it's not necessarily reflective of people, so it's not deduplicating, for example, someone who is hospitalized, and then if they're doing the test-based method of discontinuing them from isolation, and if they continue to test positive, the results of that one individual case continue to be reflected. But on the other hand, if someone is, for example, the expanded testing now that's occurring in long-term care facilities of asymptomatic or persons without symptoms in residents or staff, that's being reflected here as well. So that could skew a little bit more toward negative versus positive, but nonetheless, it's definitely adding to the denominator. And I think Dr. Hussein was also referencing the anticipated increase in pre-surgical clearance testing that will hopefully come back more negative than positive, but that will also be informing this positivity percentage. And the other clarification I want to provide in the graph that we have for positivity is just of diagnostic testing. So for example, the PCR testing, which is really focused on persons, like you said, who are ill, but a little bit is increasingly happening now in persons who are without symptoms. The last thing I'll add about the PCR testing is that as we talk more and more about contact tracing, what's being recommended, this degree of contact tracing is not occurring currently. I don't think in Illinois or anywhere, but what they're talking about as they develop this robust contact tracing force is not only will the case be interviewed and then the close contacts identified and they're recommended for isolation and quarantine, but then additional contacts will be identified, and whether they're symptomatic or not, because they're linked to that known case, they will be recommending testing for all of them. Now, I don't think we yet have the capacity to be recommending testing for every contact that's linked to a case, but that's what we're talking about. So that's more the PCR testing. The other kind of testing that I think we've been hearing about a little bit more at a population level is the antibody testing. And I think that's what can be applied at a population level for public health surveillance and also for vaccine development. It can help be an indication if someone is in fact developing antibodies in response to a vaccine. Now, the Infectious Diseases Society of America has cautioned against individual use and interpretation of antibody testing, but fortunately we do have the PCR test, and recently there was a rapid antigen test that was FDA approved. So anecdotally, in talking with one of the local hospital laboratories, they did share that they have the antibody test, and they are offering it on a very limited basis. I think they're in conversations with their leadership to expand it, but I think they're still considering what the indications are for it and what the interpretation is, because we don't yet know if presence of antibodies confers, if we know that presence of antibodies confers immunity, and if there is immunity, what the duration is. So that kind of interpretation is still pending. And then one of the statements of caution by the Infectious Diseases Society of America is that further, until more evidence about protective immunity is available, serology results should not be used to make staffing decisions or decisions regarding the need for personal protective equipment, because there's been some talk of ideally where if we know someone's immune, then maybe they don't need to be as careful, or we don't need to expend the PPE supply that we otherwise might need to. But I think they're actually recommending a pause on any kind of application or interpretation in that direction. I did want to add that it was interesting to learn in talking with this hospital lab person that what they're seeing from their testing, and I think he was also citing what Abbott in their antibody testing, is that in our region, what they're seeing is about an 8 to 11% of antibody levels that would be considered above the negative threshold. So that was the first I'd heard in our area. Now, moving forward from that, if we were to consider some sort of, community-based testing or population level testing, like they did in Santa Clara County with Stanford. Now that was really Stanford led, and then the Santa Clara County Health Department was a participant and supported that study. But we as a health department would frankly not have the capacity to implement a county, a study like that or a surveillance project. But I think if we had an academic partner that we wanted to approach or explore some community-based testing, I think that would certainly be an option. I just think it would be important to proceed very cautiously and with appropriate study design and, human subject safety protocols, and so that we have the appropriate experts that are interpreting and then, compiling those data in the appropriate manner. I hope that helps provide some background of at least our understanding at this time. And Karen and Chris, please chime in if you'd like to add anything.
Can I just say something? Up until the last minute of your answer, I was going to tell you that you didn't answer my question, as much respect as I have for you. But I think you did toward the end. And this isn't something that I would expect our health department to do on its own. I think we would contract it out, whether it's through an academic institution or some other institution. Certainly, I understand the enormity of the project, but again, it just logically seems to me that the more diverse the group that you're testing, the more likely you're going to get a more accurate determination of how the virus affects everybody. It's as if all we did was test people who were in long-term care facilities, we obviously would have a greater positivity rate. If all we're doing is testing people who think they're sick or who are sick and are going for a test to see if they have COVID, we're going to get a higher positivity rate than if every member of this board, who hopefully to God doesn't think that they're sick, would get tested. And the results might come out the same. It might come out to be greater. We don't know. But again, because we don't do the testing that way from a community-based standard, we're never going to know. We're never going to know how many people in DuPage County of the 950,000 residents have COVID until we're able to test everybody, which is obviously not going to happen. But we do we do the community-based testing based on what we would customarily do for other types of testing of this sort. So I'm glad you think it would be helpful. I understand that we don't necessarily have the capability now, but I think it's something that we really need to begin to move the ball on. I've asked Chairman Cronin to talk to the governor about it. What it will do, I think, is show the governor and the rest of the state where we're at in DuPage County, in particular, and hopefully the results of that will be significantly under the 20%, so that we can possibly begin to move on to some sense of normalcy somewhere down the road. And again, I'm merely also voicing what has been brought up to me and is brought up to me every day by various people about why we don't do this. And I think we got to get started on it. I think we really got to push. It's going to be my mission in the next weeks, and I'm going to do what I can to get it done. As long as it's something that I think is going to bring some legitimate results. I mean, if the medical professionals don't think it's a good idea, then tell me why, and we won't push it. But from a layman's point of view, I don't see how it can hurt. Sorry, I didn't mean to dominate the conversation.
I'm sorry. Go ahead, Sam.
Go ahead.
Rashmi, I'm sure you can
So this is Robert Spinner. I mean, I sit on a call every morning regarding lab results and who to test, not to test, and all that. And I will tell you, at least from what I've heard, from whether you talk about IDSA, which is that International Infectious Disease Society, or our own ID docs and all that, you could test all you want, but just because you didn't test positive tonight at 7:00 doesn't mean you're not going to test positive on Saturday at 2:00. So that's the reason why they want symptoms and all that. So testing isn't always the end result. We do have more tests available now, so you might want to do that. Somebody brought up earlier about, I think Dr. Hussain said about elective testing. So we do a fair amount of elective testing as of Monday between both of our facilities. I didn't follow up with Rush Copley, which is probably more towards our area out there. But we've had nobody test positive that had a surgical procedure coming into Rush or Rush Oak Park Hospital. So I think just by doing that, by doing the pre-testing for surgery, you'll get a bigger number. But, from what I've been hearing, because believe me, I have every elected official in every Cook County, every mayor wanting to, me, it can get me, get my kids, get my wife, or whatever. And it isn't the end all be all. And the other thing is I've already had the antibody testing, and what was said is absolutely accurate. It's too early to tell. All it does tell you is if you had a COVID test or not. It's the same to me whether I had a COVID test, get tested for COVID, or get tested by the antibody, because it doesn't do you any good either way, because they don't have any definitive results of if you do show some antibodies, are you immune from it? My voice is cracking up. I've talked too much in the last 2 days. Sorry. But I don't disagree. I think there's more to get. So I guess the honest answer is if you want, the governor will definitely give you, will help you get or secure testing. The key is you have to get somebody to do all this, and it isn't easy. So my COVID clinic, which is a drive-through clinic, basically every 10 minutes somebody comes by, I have to staff it with 10 people because only nurses can do it, not MAs, and I have registrars and everything else fully in PPE and the whole ball of wax. Not as easy done as you think it is. I know there's a lot of doctors on the committee, but I have to operationalize it. So it's a lot harder to operationalize it than it is just to say to order it. And you can only, and the machines can only run so many a day. Whether you go to Rush, UFC is running 1,000, Rush is running 500 to 1,000. We contracted with LabCorp and Quest to take our backflow or overflow, just like every other hospital has throughout the country, and their backlog. They are moving it a lot quicker. There's a lot of issues. I don't know if you've heard or read about it regarding these rapid tests. I get 780 a day from Abbott, and I can tell you sometimes that, we did our own certification or some, what they call testing. Some tests show that they're 80% accurate. Some show they're about 92% accurate, which then allows for slippage. So, and there was a study that somebody sent to the CDC, I think New York University, saying the accuracy rate's even worse than that. So,
right.
So Sam, I guess what I would say is I wouldn't follow my sword yet about testing until I think we get a little more data on it. And what you're talking about is what we're doing. We're tracking people. Most of the academics have some study going on already. whether it be with some type of vaccinating company or some type of pharma company. They're already done. If you want to try to get one with the with the Board of Health, I'm sure you can maybe become part of a study that maybe Northwestern is doing, or one of the other ones. I don't know if Advocate or Aurora is doing one, but I think Northwestern is. That's all I want to say. I mean, yeah. So that my 2 cents is testing isn't the end all be all yet.
Can I clarify one point? So I want to make sure people understand there's 2 different types of tests. And Rushmere was alluding to this. There's a PCR test, which measures nucleic acid. That is a test that is currently being used for patients who we think might have disease. The tests that have not been rolled out in a broad way yet are antibody tests. Those tests can tell you if you've had disease in the past. So I think what Sam is referring to, as far as widespread testing, in order for us to get an understanding of how many people have had this in DuPage County, I think you're talking about antibody testing, which is currently not widely available.
No, I'm not. I'm not talking about that, Doctor. I'm aware of the different types of tests, and I'm not even talking about the antibody test. I'm talking about, again, and I don't dispute the experts. And Robert, to your point that testing isn't the end all be all, I understand that. But right now, that's all we have. Right now, that's how the governor's determining whether people can go back to work and whether businesses can open. It's based on testing. So we're either going to use the testing results that we have, or we're not. So until we come up with something different, that's all we have. And I'm not talking about the antibody test. I'm talking about the same test that's given at Aurora for people who think that they might have COVID, or the same test that you're giving to your people at Rush, Robert, but doing it in a way that's distributed among the general population in the county based on a variety of different factors to get a handle on it. I'm not suggesting that it's going to give us the absolute it's going to absolutely identify who's got it or who doesn't have it. And I know that you can test negative today and positive tomorrow. But again, it's all we have. And it would give us some, I think, a better understanding of how it affects the entire county. So, maybe I'm not explaining my theory here properly. But if we're going to test, then I think the testing more than just sick people is the way to go, because we're just not going to get an accurate read on it. And I again would assume that it would be much lower than 20%. But I'll defer to others. But I'm not gonna be deterred in my quest. I will tell you that right now. I think that we need this testing, and until somebody tells me that it's not going to do any good, I'm gonna continue to push the governor for it. At least until something else comes up. So. But thank you to Kevin and Chris and Dennis and these are great charts, and they really do answer a lot of the mayor's questions, I think, on Monday mornings as well. So it's really interesting that if you go back, Chris, to the chart about age, I found it really was one of the first chart I think you had, that there's the greatest number are people literally between the ages of 30 and 60. And yet, the people who are older, the most vulnerable, as we hear and read about in the newspaper, in their 70s and 80s, are lower in percentage than those who are much younger. Although the other chart that you showed that the more significant number of deaths come from that age group. Mm-hmm. So even though there's fewer COVID positive people who have it, more people die, and that's presumably expected. So it's just there you go. So those are the dots, and do we know, or I'm sure we do, but off the top of your head, if you will, of those people who are in that 70 to 90 range or whatever, are we still looking at maybe 65 to 70% of those people are in long-term facilities, nursing facilities?
More. I think it's been 73+%. Actually, okay. The graphs were just updated today. So yeah, it's consistently been over 70%. Yeah, Chris will take us to it.
Okay.
So the cases in that, the long-term care facility associated cases are 19.7%. However, the deaths are nearly 76% that are long-term care associated.
Okay.
Very significant. Thanks, Chris.
Any, okay, Karen, I'll turn
Okay,
it over
but wait.
to you or Chris.
Yes, thanks. But wait, there's more. There's more. We have more to share. So we'll go back to the PowerPoint presentation. Okay, next slide. Is positivity. So then let's go to the next slide. We've talked about positivity. We want to talk about some of the disease monitoring as far as our surveillance. And so when we say case and contact investigations, that number, just as a reminder, today is 5,457 cases that have been officially assigned to the health department to follow up, investigate, and then do contact tracing, albeit we are doing close contact tracing at this point. To put it in some perspective, last year, the entire year, we had between 3,500 and 4,000 cases, total cases of communicable diseases that we were responsible for investigating and tracking. So we've already blown by our annual number in the first few months of 2020. To that point, we have FTE resources available. We have trained up. We started with 6 members of our CD-EPI team. We had previously trained some internal staff to assist with STD work. We immediately moved about half of those into the work being done through CD-EPI. We now have added over the course of kind of incrementally, a week at a time, 10 to 15 staff from each and every one of those 5,457 individuals. Now, the goal is somewhat ambiguous because some models for contact tracing for a community our size indicate that we need about 1,000 individuals. Where we're setting our current goal, internal goal being realistic, is around 200. So Laurie has been working intensively in this area to make sure that people that we bring on have the adequate. First, we need them to have adequate hardware, so they need phones and computers and things like that. But next, they need training, and then we have reporting available to monitor the processes that they use. A little bit about congregate setting outbreaks being investigated. Certainly, we talk a lot about long-term care facilities, but next slide, you will see that we've had many outbreak-associated cases. And when we talk about outbreak-associated cases in congregate settings, we're talking about long-term care facilities, certainly, but also workplaces, schools, or large gatherings. So we've had 1,600 total cases. Of those, the vast majority have been confirmed and have had a total of 204 deaths. Next slide is a breakdown of where those cases come from, or those outbreaks are associated with. And you will see that 76% are either in long-term care facilities or workplaces, although one could say that, you know, a restaurant or a hospital or a school is also a workplace, but it provides us with a bit of understanding of the outbreaks in our community. Any questions on disease monitoring or surveillance? One of the other points that I want to be sure and mention is that we applied for and have received approval to hire 4 additional members of our CD-EPI team through the CDC Foundation. We were approved to hire an additional 2 epidemiologists, 1 disease specialist, and 1 nurse who will work primarily with or exclusively with schools around COVID issues. These will be assignees from the CDC Foundation. However, we will have the opportunity to vet these individuals and provide our recommendations for hiring. They'll be assigned to us for a year, and there will be no local resources needed to support their staff or any other expenses related to them. So we're very excited about that opportunity and have begun assessing the applications that are being shared with us.
Karen, are we going to have these people from CDC indefinitely, or is there a time frame that we need to give them back?
Yeah, we need to give them back after a year. But we're hopeful that within that year that we can fully leverage not only their best skills while they're with us, but also perhaps look at opportunities for finding local funding to keep them on board if needed.
Great.
So disease monitoring and surveillance is one of the priorities that we have in our response. But next slide, you'll also see that we're responsible for doing a lot of education and public information. And so as we've talked about, we had the emergency call center stood up. And as online information has become more available, we started it in March, on March 10th. You'll see that we had a big spike of calls coming in, and then those calls have been declining over time. We feel like that's probably because there's online information that's becoming more available. So now we're taking the people that we have trained as call center staff and moving them into our case investigation work. So we will start training with about an additional 20 FTEs starting on Monday, and they will help us to help support. Meanwhile, the calls that are coming in for COVID will be fielded by our intake and referral team rather than having this 50-person operation in play. So we're very excited about that. Next slide. We've also been doing a lot of work, and when I say we, I mean the team that is really being driven and coordinated by Kim Siebert. She's got 3 primary objectives. 1 is an educational advertising campaign. 2 is to really support the dedicated coronavirus subsite, which the data that we just walked through is part of. And then finally, we want to do some social media campaigns highlighting general acts of kindness in the community, as well as promoting the dedicated team of public health professionals at the health department. And that is hashtag do your part, DuPage. Next slide. So the strategy is to utilize a broad selection of digital and audio platforms to reach a large cross-section of the population. And next slide, you will see that we've been quite successful in using ads on YouTube or Roku, Amazon Fire Stick, and Apple TV, across to mobile ad messengers, Spotify, and WGN Radio. We've achieved 15 million impressions with a total campaign investment of $90,000. These next couple of slides I'm going to flip through rather quickly because they provide you with an idea of the different kinds of information that we've been sharing. This is Facebook. The next is both Facebook and Twitter. The following are short videos that address community concerns on the left, that being the food supplies and where to get additional support for food, as well as providing a broad awareness on the right across our organizational staff and how we're all working differently. So there's that. Next slide shows how we have built up our Facebook following. Next slide talks about the results from Twitter. We have also developed a 30-second video that was watched by almost 300,000 individuals throughout the entire 93% of the time it was completed. So either they clicked on it and walked away, or they saw it all. So we'll go with the latter. We've also been using these kinds of mobile ad messengers. So if people are looking up, for instance, on WGN, we have a reminder to do their part. And then finally, we have, and I've heard it many times on WGN, had radio spots reminding people to contribute to slowing the spread of COVID-19. Next slide talks about the news stories, and although we had more news stories occurring in March, actually our reach was greater in April. So, you know, more is not always better. The following slide talks about kind of some of the highlights that we had. And then the following indicates one of the strategies that we've been using more recently, prioritizing different ways that the DuPage County Health Department team have been supporting individuals, communities, and business with good news stories. And this was our first, talked about our emergency call center, and we'll be following up with a story on how we're supporting essential businesses to make sure that both their customers and their employees are staying healthy and have what they need. You'll see the page views has gone, we've had more than 1 million page views since January 30th. And so that's a little bit about our health education and public facing information sharing. Any questions on that?
Karen?
Yes.
This is Mindy. I just want to make a comment that I really like the good news, because there's a lot of bad news right now. So I think that the point that you guys are taking to put some good, positive things out there is really helpful for people.
Good. Yeah, thanks. This has been kind of an unremitting, you know, every day I kind of wake up and think, okay, did I just dream it, or is this really happening? And I think, unfortunately, that's the case. And so we need to infuse some ideas of how people can get kind of their perspective shifted back to healthier and more adaptive ways of dealing. Another objective in our response plan is to work to secure and distribute necessary PPE to our first responder community. We have a team of DuPage County Health Department staff in a joint operation with OSM staff who have been working out of the fairgrounds using County Department of Transportation drivers, as well as we've added our health department facility staff to deliver supplies. This is probably the most concerning area as far as preparedness, that we're still at the stage that our healthcare workers, our long-term care facility workers, our police and fire are all having to use what's supposed to be disposable, one-time use in conservation and reuse strategies. So I think I think Rashmi actually used the term blasphemy. It would have been blasphemous a year ago to think that you're going to reuse an N95 mask, or you're going to try to conserve gowns or things like that. This continues to be a significant need. I cannot overstate it. And supplies are simply not available to us. So this will be an area that we need to watch very closely as we look at opening things up. The next area, next slide, talks about housing. And we certainly know that we have people who are unstably housed within our community at all times. Those people typically were staying in congregate settings, so they would go to maybe 5 or 6 different churches throughout the community, and then they would circulate. We knew that that going into this, and with the wisdom of some of our homeless providers, they identified that they didn't want to continue that practice, and so with the support of county board dollars as well as their own fundraising, we have at least 180 hotel units that are currently serving our homeless population. We also have been working with healthcare systems in case there was a need for additional hospital level care. That need has not been realized. Our health systems have, through their surge capacity planning, have been able to manage the level of hospitalizations required. But we have identified several gaps or areas of need where inpatient stays are extended due to either insufficient long-term care capacity or other social needs that prevent an individual from going home. So OSIM and the county board initiated a first responder housing project at Wheaton College. The actual operations of that site have now been transitioned to the DuPage County Health Department, as we are providing the ongoing operational support as well as the medical oversight. Individuals, however, who are not first responders but who have tested positive are not eligible to go to that site. And so we have been working with a regional housing solution that has been stood up by the state and the National Guard up in Schaumburg. That site will not be available to us as of tomorrow. So we are working very intently in identifying local solutions to be sure that people who are symptomatic, who are sick, who are COVID positive, have a place to isolate or quarantine. Question on housing? Questions on housing? Another area that we've talked about are the weekly meetings that we have. Meeting with mayors and managers. We start our week off 10 o'clock on Mondays with meeting with mayors and managers, but then we have weekly calls with school superintendents and the ROE. We talk with police, fire, and EMS. We provided updates to county board, and increasingly we're talking to managers and local businesses about elements of both our response as well as our recovery. Next slide really identifies how we've been operating. And certainly we have continued to track illness over our employee population. Andrea has served as our safety officer, and every day we track not only the symptoms of people who are working, but we also track individuals working on site, but also track individuals who are working from home. We have had several employees who test positive. The good news is that all of our employees have recovered. That is not the case, however, with our employees' extended families, and several have experienced death to their families, and some of them tragically have had multiple deaths in their families. As we begin our own plans to return to work sites, we are looking at all of the same elements that we've been working with other businesses around, and those are, kind of outlined in this graph or this slide. We have leveraged the early work that continues with our IT support, and we actively, actually, in a week, and I can't remember exactly the week in April, our 2020 productivity and billable time for that particular week for our medical team, which is our psychiatrists and nurses, actually exceeded the same week from 2019. So it's been incredible how our staff have embraced this new virtual world. I think there will be many elements of this that continue far after COVID is in our rearview mirror. And then another strategy that we use to keep our staff informed, engaged, and updated is Adam helps provide daily all staff emails. And that has been something that we have used consistently after we kind of shut down our on-site operations and transitioned to full response mode. So with that, any other questions?
Karen, I have a question. This is Lani Wilson. Any chance that the health department will be doing testing anytime in the near future or distant future?
Testing for COVID?
Yes, ma'am.
We will not. We don't have the resources, human resources, to coordinate testing. However, I think that if we can engage in some sort of partnership for testing, that I'm hearing from President Tornatore that is a priority for us in the upcoming weeks. So yeah, we'll be involved.
That testing is certainly part of the solution to this problem, and even if we can't do it, if we can coordinate it in some way, and as soon as the testing is available, we want to be on the front line of coordinating that and getting it done as widely as possible.
I would just comment Bob Larson, one other thing that at some point, and I know everybody's resources are stretched, but there has to be consideration given, and I know there's sort of some thought to this, of the non-COVID-19 related health effects of the crisis. Whether it's a bump up in suicide rates or overdose rates, such as the coroner is talking about, and that was mentioned earlier in this meeting, there are other adverse effects of this. You mentioned people not going to their health appointments, probably people's diet, all kinds of adverse health issues of being socially distanced and staying at home that have to be counterbalanced against the risk of the COVID-19 spread. And I think that's an important consideration as we look at phased opening back up.
Absolutely. And top of mind is something that Dr. Munir actually raised last month with childhood immunizations. And so, the last thing we want to be doing is having an outbreak of measles in our community. And meanwhile, we've seen that, immunization rates and both pediatricians and family practice docs are saying, people are scared to come in. So we are absolutely concerned with those other unintended consequences of the stay at home and the isolation.
For the record, I went to my primary for checkup on Monday, so.
Good for you. Okay, back to you, President Tornatore. I think you're on mute.
I am. Thank you. And thank you for all you've done and continue to do. And we're there for you. Okay, that concludes the public health update. We will move on to approval of the minutes. I will entertain a motion to approve the minutes of April 9th, 2020.
Lanny Wilson, move to approve.
Bob Larson, second.
There's a motion and a second. Are there any additions, corrections, or deletions? There being none, we're going to do roll calls for everything, Penny, because it's just easier for you. So take the roll, please.
Okay, hang on.
It's okay.
Okay, Dr. Wilson,
Yes.
Ms. Bottoms,
Yes.
Ms. Finch,
Yes.
Dr. Hussein,
Yes.
Mr. Larson,
Aye.
Dr. Munir, Mr. Spadoni,
Yes.
President Tornatori,
Aye.
Dr. Weeks.
Aye.
Is Dr. Scouten on? Or Mr. Thurston? Okay. Mr. President, motion passes.
Thank you. And the minutes are approved. Moving on to the treasurer's report. Mike, I will turn it over to you.
Thank you, President Tornatori. As of March 1st, the Health Department General Fund balance totaled $23,510,372.64. Receipts for the month totaled $2,316,684.30, and disbursements totaled $3,082,520.18, leaving a month-end total in the Health Department General Fund of $22,744,536.76. Combined balances in all four health department funds as of March 1st totaled $31,984,045.67. Combined receipts for the month totaled $2,329,482.95, and combined disbursements totaled $3,481,153.14, leaving the combined balances in all four health department funds at $30,833,375.48. Investment earnings recorded to the general ledger in the month of March for all four health department funds totaled $34,859.07. Including the March earnings, year-to-date investment earnings in all four funds totaled $149,892.07. Any questions?
Any questions of Mike regarding the treasurer's report?
Just a comment, Mr. President. It's Bob
Sure.
Larson. Obviously, one of the things we took up as a county board last month was giving taxpayers the opportunity to delay their tax payments if they could justify it without penalty. But the strong accounting and work of this board and making sure, and the staff's tremendous job of making sure that we have good cash balances will prevent that from creating any threat to our cash flow between now and September 1st, when everybody will be obligated to start paying their real estate taxes.
Yes, I agree with you. And Mike has assured us that we're in good shape, even with the moratorium, if we will, for 3 months on payment of taxes to only those people, by the way, who do not have an escrow account. If someone's got an escrow account with a bank, they still have to pay by June 1st. We're not going to let the bank sit on the money and earn interest on it when we don't. Any other further questions on the treasurer's report? I'll entertain a motion to approve the treasurer's report.
Bob Larson, so moved.
Or second?
Lanny Wilson, second.
Motion and a second. Please call the roll.
Mr. Larson,
Aye.
Dr. Munir, Dr. Munir.
She's on mute.
Okay,
She
I see
nodded
her.
her head yes.
Got it. Mr. Spadoni,
Yes.
President Tornatori,
Aye.
Dr. Weeks,
Aye.
Ms. Bottoms,
Yes.
Ms. Finch,
Yes.
Dr. Hussein, Dr. Hussein.
Yes.
Okay.
Yes.
Mr. President, the motion carries.
Thank you. And the treasurer's report is approved. Under consent items, I didn't see any in the packet, so I assume that we don't have any. Is that correct?
That's correct.
Okay. And we'll move on to action items. I'll entertain a motion to combine and approve items 8(1)A through G under purchasing. This is the AT&T contract, to Experian Health contract for professional services, to Joint Commission accreditation, to Konica Minolta, to Colette Petit for professional services, Thomas Interiors, and to Dr. Margaret Kierkegaard for professional services. I'll entertain a motion to combine those items
And approve them, so moved.
and approve them as well. Yes.
Second, Lanny Wilson.
There's a motion and a second. Any questions of any of these individually or collectively? Okay, there being none, roll call, please.
Mr. Larson?
Aye.
Dr. Manier?
Yes.
Mr. Spadoni?
Yes.
President Tornatore?
Aye.
Dr. Weeks?
Aye.
Dr. Wilson?
Yes.
Ms. Bottoms?
Yeah.
Ms. Finch?
Yes.
Dr. Hussein? Dr. Hussein? Okay. Mr. President, the motion carries.
Thank you. Do we have any unfinished business or old business? I'm looking at the screen. I see no hands raised. How about new business? Anybody? New business? I see
Think
no
we're
new
good.
business. Okay. Our next meeting is scheduled for June 11th. I hope we can be together. If not, we'll see each other on Zoom. But do we have anything for executive session this evening, Karen or Peggy?
No.
No,
Okay.
he couldn't
Yeah.
resist.
I saw two dogs pop up.
Yes.
Okay, we have nothing under executive session. I'll entertain a motion to adjourn.
So moved.
Second.
That was one of my beagles.
Second. All those in favor signify by saying aye or
Yes.
yes. Okay.
Aye. Yes.
The ayes and the yeses have it. Thank you. We're adjourned. Thanks, everyone. Have a great evening.
Thanks, everyone. Take care.
I'll be